Hello, I'm Dr. James Bogash, expert in health and longevity and creator of Bogash Life and Balance. And today we're going to talk about a tough, very constantly used phrase, and that is long COVID. And how much misunderstanding there is and how much the brain may play a role and whether or not it even exists. Let's clarify that first. The idea that people would have long-term symptoms after a viral illness is not anything new. So clearly, there are people that do not do well after an assault to their immune system, like COVID, like influenza, like any other respiratory virus that we can have. Many people with MS started with a respiratory symptom or a respiratory virus. It's not new. Chronic fatigue, Lyme's disease, which is not a virus, but the idea that our bodies don't always fully recover is not new. But those numbers are pretty small and certainly don't. The idea that 10 or 15 or 20% of people would have long COVID seems strange until you start looking at these two particular studies I'm going to point out today. But also keep in mind that there's a lot of things, a lot of misunderstanding. Twitter's always an interesting place, but there was a lady who talked about her husband having long COVID, and he just got out of the hospital from COVID yesterday. Well, that's not long COVID. 30 days is not long COVID. The average cough lasts 30 days. So the idea that, one day after you get out of the hospital, you still have symptoms, that's not long COVID. That's a typical viral or body's response to a virus. Even 2 months can be a not unusual time frame. So then let's look at these particular studies because it starts to put everything into perspective. And the first one has to do with GI symptoms after COVID. So looking at potentially long COVID, and 20% of the people who describe long COVID, it's GI related, whether it's nausea, whether it's diarrhea, constipation, abdominal pain. The GI tract is a frequent complaint. Now, 70% of COVID patients are given antibiotics, and that can certainly throw off the gut flora. That has nothing to do with the virus. It has to do with the treatment of the virus. And it's also not unusual for the gut flora to get thrown off kilter with an infection. So, certainly some of that makes sense. However, when they started looking at people who had prior mental health, so things like anxiety, depression, they were 16 and a half times, that's a lot, more likely to complain of GI symptoms. So clearly there's some connection between our stress levels, which have been high from here, and just the way our brain works and how we feel afterwards. And the GI tract is a really big, stress affects the GI tract, so it's a target for people that have things like anxiety and depression. We consider the gut as our second brain, so those relationships are not that, it doesn't come as a big surprise. This was a study in about 750 people, followed them for 6 months. And so that would qualify as long COVID. Interestingly enough, people who didn't have any mental health diagnosis like anxiety, they were after COVID, or they were six times more likely to have a psychological diagnosis. That's a pretty big number. So even if you didn't have any before, you're more likely to have some afterwards. Now, is that from the virus or is it from our body's response to the virus? But it is clear that psychological distress increased the risk of COVID, of what in this case would be considered long COVID, specifically GI symptoms. So you have to look at how much stress some people. I was just talking to somebody close to me and she's terrified of getting COVID still, and reminded her that at some point everybody will likely be exposed to COVID. I've been saying this since day one, and so if somebody is that nervous, that terrified, and they get the diagnosis, they get that test result back that says they've got COVID, how much of that is now driven by their expectations and the stress level that's tied into that, and not the virus itself? Something very important to consider as we look at this second study. And this was a study out of, can't remember where it was out of, but I'll put it in the comments. Sweden, Denmark, somewhere in Europe. But it was a large study, 26,823 people. And they looked at very interesting way to look at it. They looked at people who had self-reported COVID and whether or not they actually had COVID. So if they had positive antibody tests versus not. This isn't the time to get into discussion on antibodies, but in a situation like this, antibodies are probably a good way to check if somebody actually had COVID. And so they found that people who self-reported, regardless of whether they actually had COVID, this is somebody like, hey, I thought I had COVID, and whether they actually had COVID or did not have COVID, they were much more likely, depending upon the symptom, it go up to like 16 to 28 times more likely to complain of persistent symptoms. A good chunk of these people never actually had COVID, but they believe they have long COVID. So that should start playing a role into how much the brain plays a role in this this encompassing diagnosis of long COVID. Interestingly enough, one of the things that clearly is associated with long COVID is anosmia, or loss of sense of smell. I've had some patients that have had that loss of sense of smell, and it can take a long time to come back. Months, even a year later, some people have not had their sense of smell back. But just to show how that loss of sense of smell, how real it is, and is not related to our stress levels, the psychological component, is that people who had lab confirmed only, so whether they thought they had COVID or not, they were almost 2.7 times more likely to have anosmia, or people with anosmia were, I have that backwards. So basically, anosmia was a very real finding in people who had positive COVID, and that scenario led to about 272% higher risk. So very real with anosmia, or loss of sense of smell, and also how long that lasts. Like, there's no argument there that clearly it's playing a role somewhere in there. Another little interesting is that half of the people who actually had positive testing didn't even think that they had COVID. So when they asked if they had COVID, they said no, and it turns out that half of them did. So what's the bottom line? We have to be very careful when we talk about long COVID, and because of how much drama and stress and everything has been played around the whole COVID scenario. And there are some people that merely a positive test may actually drive the development of symptoms. And if you think that that's strange, it is not. It's something called nocebo. People can actually become sick when presented with, if they think they would get sick, so let's say they're terrified of COVID and they're asymptomatic and they get a positive test, they may actually now become positive because the brain sets them up for those symptoms. And that's a very real phenomenon that we see across medical conditions. It goes to show how much the brain plays a role. But there's a lot of people who talk about, oh, well, it's not just how many people died or hospitalized, it's all the people that will suffer from long COVID. And I personally do not think the numbers are of people that are really suffering from long-term those numbers are not what they think they are, and they're probably much more in line with people that we see that develop things like MS, other autoimmune conditions, and things like that after some type of an infection. And those numbers are definitely not 10%. And there are ways to manage and look at those, managing the gut, managing autoimmunity. Those are all real scenarios, but I do not think for a moment that it is at the numbers that people think that it is. As always, I will post a link to these two particular studies in the description. Make sure you like this video, share it with somebody who you think needs the information, and subscribe to the channel.